as far as bone sarcomas are concerned, you have to know only three main types. It is osteosarcoma, Ewing sarcoma, and chondrosarcoma. In this also again, age plays a role. Like Ewing sarcoma, it is very rare to detect after age of 30. This is mainly a diagnosis which you consider in adolescents and young children. Osteosarcoma also usually it presents in adolescents and young age group. Although beyond 40 also there is a second peak is there. Means there will be few subset of patients who will develop osteosarcoma after the age of 40. So if a primary bone malignancy I am considering in an adult, the first diagnosis which will come to mind in after 40 years of age will be osteosarcoma rather than Ewing sarcoma, because Ewing sarcoma is so rare. Beyond that, chondrosarcoma, again chondrosarcoma is the primary bone malignancy which is more common in adults. So chondrosarcoma you are pretty rare in children. Okay. So if anybody asks you based on age, what could be the probable malignancy, primary bone malignancy, if it is a kid, first thing you have to say is osteosarcoma, second thing is Ewing sarcoma. Regarding incidence also, osteosarcoma is much more prevalent compared to Ewing sarcoma. If you have 3 cases of osteosarcoma, then only you will find 1 case of Ewing sarcoma. In older age group, chondrosarcoma is the most common primary bone malignancy. You had any doubt? In after 40 years of age, if I am considering a diagnosis of primary bone malignancy, I won't keep Ewing sarcoma as my first differential. My first differential will be either osteo or chondrosarcoma. Okay, Ewing sarcoma because after 30 is very rare. Okay, so it will not be in my differentials. Osteosarcoma is the most common primary bone malignancy. If you're considering that it is a malignant bone lesion and it is a primary bone malignancy, the first thing which I will consider it will be osteosarcoma based on the prevalence. Even then, unless and until you do a biopsy, you cannot surely say that I am dealing with osteo or an Ewing sarcoma, because the radiological pattern, the age of presentation, the signs and symptoms are pretty much same in both. Okay, but management might differ, especially the chemotherapy protocol, the radiotherapy. Like osteosarcoma is not radiosensitive, so there is no role of radiotherapy except for palliative purposes. But Ewing's is radiosensitive. So sometimes when the lesion cannot be resected, then we treat them with chemotherapy and definitive radiotherapy. But osteosarcoma, we are not supposed to treat with radiotherapy because it will not respond. Same way chondrosarcoma, it is chemo-resistant, it is radio-resistant. Only way of curing it is surgery, nothing else. Okay, only when we are not able to operate, either because the lesion is at a place where you cannot resect it safely, or it is already metastasized, then only we consider other options. But for curative purpose, we never consider chemo and radiation in chondro, and radiation is not considered for curative purpose in osteosarcoma. Okay, I don't think so you will require soft tissue malignancies. Now metastatic bone lesions. Okay, the most common cancer in India is, you stay in West Bengal, you would have seen people eating Santiniketan and all. So most common malignancy still in India is oral malignancy only, despite whatever government has tried to do. Okay, so in our scenario, it is oral carcinoma, which is the most prevalent carcinoma. After that comes lung. In females, it is cervical as well as breast. Okay, so among the malignancies also, few malignancies will have more predilection for spreading to bones. Among that is lung, breast, prostate. Prostate frequently is diagnosed after it is metastasized to bone. Like Joe Biden, the former US president, was diagnosed with prostate CA because he developed bone metastasis. So because he was diagnosed with a metastatic lesion, so when they again evaluated him, they found out that he is having prostate CA. So his diagnosis actually correlates with his age. He is almost 90 years of age. He definitely would have some prostate issues. So the chance of him developing a prostate CA is very high. And because he had prostate CA, he developed bone metastasis. And that led to ultimate diagnosis. Okay. So that's why I'm saying in bone malignancy, it's not like you can just blindly say. See, oral carcinoma, everybody will know. You see a lesion on the lips or in the mouth, you will say, yeah, it is oral carcinoma. You see a lung patch or a CT scan shows you a neoplastic mass in there, you will say most probably it is a lung carcinoma. Bone, it is not like that. Bone, even if you see a lesion, you have to correlate by the age, by looking at the pattern of destruction of the bone, and then you have to make a guess whether it is actually a primary bone malignancy or you are dealing with something else. Okay. So how you approach a patient when you find a patient with a bone tumor or bone swelling? You had a class of general surgery, right? So you would have done a class of how to examine a swelling. So how do you approach? First history, man. Always it's a history. Okay, history is the one thing which will give you clues. Because again, I told you, last age is very important. So if a 60-year male presents to me with a swelling around the knee joint, which is expansile, which I find on examination that most probably I am dealing with a bony lesion, my first diagnosis will be what? What is the most common primary bone malignancy in adults? Correct. So 60 years with a lesion in the distal femur, expansile lesion, what will your first diagnosis? Metastasis. After that, multiple myeloma, blood hematological malignancy. After that, bone malignancies. Because as I told you previously, bone malignancy is actually pretty rare, especially in elderly. Okay. So I will not keep my differential as a primary bone malignancy in a 60-year-old age group. Compared to that, when a 10-year-old kid comes to me with a rapidly expanding swelling around the knee joint, okay, which I find that it is most probably in the distal femur or proximal tibia, then my first guess will be most likely I am dealing with a bone tumor, primary bone tumor, whether it is benign or malignant, that we will see at a later stage. Okay, so always it is a history which gives you a clue. So in history, again you have to see the age, okay, occupation. Again, if a patient is a chronic gutka user, tobacco consumer, he has already been diagnosed with a oral cancer, for which he was on treatment, say 3 years back, he had completed his therapy, and he presents towards with new onset lesion, bone lesion. What will be your first guess? Metastasis, yes, because he is already a treated case of CA, carcinoma. So many of the times what happens is recurrence won't happen at the primary site. Many of the cancers, it is found that the recurrence will not be a local recurrence, it will be a systemic recurrence. And the most common visceral organ of systemic recurrence is lung and liver, unless it's a primary lung malignancy. And for other tumors, for bone, it is lung only. So if you have a lung cancer which you have treated and then patient presents with a bone pain or a lesion in the bone, your first guess should be maybe I am dealing with a recurrence of the previous malignancy. So that's why history is very important. Because the patient gives you a history that I have been already a patient of cancer, I am on active surveillance, or I go to see my doctor and he asked me to see you. Then first thing you will say is maybe, or you might not say, but you will think that most probably I am dealing with a metastasis only. But compared to that, a patient who comes just to you complaining that I am not able to walk, I have a swelling around the knee joint, my age is around 12-14 years, and this problem has started only for past 2-3 months without any previous history, then I will think, okay guys, I think most probably I am dealing with some primary bone tumor only. Whether it is benign or malignant, that I will see at a later stage. Okay, so that's why history is very important, especially in bone tumors, because remaining swellings, most of the time you can see and guess that this is what it is, because the character will be same. But it could be infection also. So that's why, that's why history is important. If suppose the kid says I am daily having fever, I am having evening rise of fever, or I had a injury, after that blood came out, then the wound is not healed, there is pus coming out, and after that I have noticed that the swelling is increasing in size. So then those are the signs that you might be dealing with an infection rather than a primary bone tumor. So that's why history is important, because it might give you a clue whether you're dealing with an infection also. Okay. So first thing you have to ask is how long you have symptoms. First is the age that you have to consider. The previous treatment history, if the patient gives you a history, like a patient of TB is there, he has been treated with TB say 6 months back, he is still currently on treatment, and he is saying that as of now the doctors have told that it is not working for me, means it is relatively a resistant TB, and then he develops some new lesion. So then I won't think that bone tumor is a primary diagnosis, then I will think maybe he might be having disseminated TB, which is causing him to develop some bony lesions. Okay. So how long it has been, whether it is painful or not, whether it is increasing in size, a swelling which has been there for say 15-20 years. The patient says, I just came to show you because I think whether I need to do something for this or not. But if it is there for 10-15 years and it is not increasing in size, most likely it might be something which is benign and which might not need treatment also. Like osteochondromas, Osteochondromas have a growth peak, that is, that coincide with the growth peak of the child. So these are basically lesions which grow in the metaphysis and grow when the child has a growth peak. So boys usually have a growth peak around 7 to 10 years of age, then 15 to 17. Girls have a growth peak around 13 to 15. Okay, so those are the time periods when the kid will complain that I am developing a swelling. Okay, and the swelling is increasing size or I am developing symptoms. But if you're on radiology, if you're sure that it is osteochondroma and the age and the symptoms correlate with your finding, and there are no warning signs that you're dealing with something else, then usually you're not supposed to do anything. Because an osteochondroma will grow when there is a growth spurt. But after the age of 18, once the physis has fused, it should not grow. Compared to that, a 34-year-old male comes to me he's saying that I was previously diagnosed with osteochondroma. Now today, past few weeks, I have suddenly noticed that it is rapidly increasing in size. Then my first guess would be most likely it might have converted into a sarcoma, because osteochondromas, although rare, have a tendency that they might convert into sarcoma. So there are some pre-existing bony lesions which might predispose you to a bone malignancy. One of them is osteochondroma. Other thing is, if you had a previous history of radiation, means you have received radiation or something, like in the younger age group you have been diagnosed with lymphoma or other hematological malignancy for which you receive radiation to that particular part of the body, and after 10 years suddenly you notice that there is a swelling which is arising from the bone, then I would think that it might be radiation induced sarcoma. So radiation also can induce a sarcoma, although it is very rare, but then that has to come in your differentials. Okay, so that's why I'm saying history is important. You have to talk to the patient, you have to ask him whether what are the previous history, whether any significant history of TB is there or not, whether any significant history of a previous cancer treatment is there or not, when he noticed the swelling, if the swelling has been there for a long time, and whether he's having any symptoms or not. Osteochondromas, when they present, they might have symptoms because they might have injured themselves while playing. So if it is something which can be managed with conservative therapy, you will not go in and excise that lesion just because patient is having pain. You will always give a conservative trial if you believe that it is not a malignant transformation. But if it is a malignant transformation, then you have to further investigate. Okay. So I guess we have covered this. Pain, what are symptoms? Pain will be there, usually night pain. Okay. Then if it is the swelling is around the joint, that the movement of the joint will be reduced. So child or the patient will complain of stiffness, means reduced movements. The local effects will be there. If it is rapidly increasing in size, the skin will show changes. Frequently we find that the rapidly growing osteosarcoma, the veins will be very much dilated. There will be muscle atrophy will be there, but because of swelling, the skin will be stretched out. You will see stretch marks and you will see multiple dilated veins. Okay. Then signs will be obviously a bony lump or a swelling which is you feel on examination arising from the bone. Okay. Then usually it is periarticular. So primary bone malignancy also usually grow around the joint, because these are usually in the physial growths and they occur at the time of rapid growth spurt. Diphysial bone malignancies although are there, but they are rarer compared to periarticular malignancies. So these are few of the presentations of a bone tumor. So you can see this, no? So there is swelling around the knee joint. Okay. So the patient has a fixed flexion deformity, means he is not able to extend the knee completely, and he is not able to flex also because the swelling is so large, it is causing a mechanical block. Along with that, because of the pain, he is not able to actively move his joint. Okay, what is this? What is that mark? Sorry? Somebody said something. You should speak up, man. I know you won't be knowing anything. If you speak up, then only we can have a discussion. Somebody told sinus. Who was that? You told sinus. Okay. So what are the characteristics of sinus? Osteomatis is the diagnosis. Because of infection only you develop sinus. So how does the sinus look? Sinus will have some opening, no? There will be pus discharge will be there. The surrounding skin should have signs of inflammation. There should be induration. There should be erythema. Correct? Do you find any erythema over here? The adjacent skin is similar, no? So this is a biopsy scar. Okay. So a patient who's undergone a biopsy, so that is another clue for you. So if you if you are dealing with a swelling and he has already undergone a biopsy, and the patient tells you that he is on chemotherapy for past few days or few months, then automatically your differential first will be bone tumor, na, or malignancy, because he is giving you a history that he underwent a biopsy, he underwent chemotherapy. Always with chemotherapy, you won't give for an infection, you will give antibiotics for infection. So that's how history helps you. So if you talk to the patient only, then he will tell you. If you don't ask him what is that, then he won't tell you. Okay? And what is this? So here what is this? Is this a sinus? Looks like sinus. So is it a sinus? Looks like sinus, feels like sinus. Is it a sinus? Yeah, it is, discharge is there, na? It's sinus. Okay. So in cancers, na, especially extremity cancers, if it is very extremely rapidly growing lesion, no, at some point of time, it might happen that it will break the skin barrier. That is called fungation. Okay. If fungation happens, and that too in a very short duration, then that is another indirect clue that you might be dealing with a malignant tumor rather than a benign tumor. Because although even aggressive bone lesions can present with fungation, but it is unlikely. So this is actually not a sinus, this is fungation, because there is no sign of infection. Again, in this also history will help you out. So when you take the history of this patient, he will tell, I don't have fever, I had a swelling which suddenly ruptured, and now some clots are coming out. It is not pus, it is clots. Clots because the bone tumor is extremely vascular, and the clumps of tissue which is coming out is actually tumor which is coming out. Okay, so that is the difference between sinus and a fungation. Because in fungation, there won't be any history of pus, or there will be minimal pus, rather than it can be superimposed infection. But more of the time, the patient will say that most of the time clumps of tissue come out. Okay, and this, what is this again? This is a swelling. What is that mark? Correct. So when you see, then only you realize that here also you have a mark. What is that? Biopsy scar. Okay. So there is an obvious swelling, no, in the scapular region. You can make it out. And there is a biopsy scar is there. So based on that image also you will think it might be possible that I am dealing with a bone tumor. Okay. Whether it is aggressive or benign or malignant, that we will see at a later stage. But this is what happens when you take a history, because history will give you a clue. Okay. So what you look for are skin changes, just like a swelling only. First comes skin. Okay, whether any skin changes are there or not, whether there are dilated veins or not, whether the skin shows signs of inflammation or fungation or not. Okay, whether surrounding area there is atrophy or not, muscle atrophy, because that is something which is visible. Okay, then you ask for movement, whether the movement is painful or the patient is able to do full range of movement or not. Because if he is able to do the movement but terminal movement is blocked, then it might be not be because of swelling, it might not be because of pain, but because of bony block. Because the bone is expanded, it is preventing the joint from moving in complete range of motion. Okay. So again, you have to see for what is the location of the swelling, whether it is arising from the soft tissue or it is arising from the bone. So how do you confirm whether it is a soft tissue swelling or a bony swelling? No man, we are still in clinical examination. Na? On clinical examination, how will you tell? Huh? Palpation, how? You tell me, na, how you will say, how will you rule out that it is not a soft tissue swelling? Anybody wants to volunteer from this? Correct. So, what do you expect? Correct. It won't be mobile, no, because it is arising from the bone. Bone doesn't move unless until you move the bone. So any swelling which is found to be arising from the bone, when you feel the palpation, you are not able to find out the margins of the swelling, and you feel that it is arising from the bone, and it is not mobile in any direction, means either mediolateral or longitudinal direction, chances are it might be arising from the bone. But some swelling which is freely mobile over the underlying bone, then it definitely is not arising from the bone. Na? Bone doesn't move. Your bone doesn't move unless you move the whole bone. So a swelling which is arising from the bone also won't move unless you move the bone itself. So that is the clinical way of finding out whether it is a bony swelling or you are dealing with something which is soft tissue. Okay. Sometimes soft tissue sarcomas can get adhered to the bone, or some benign conditions are there in which the swelling will arise from the soft tissue, but it will stick to the bone. In those cases also, there are ways of finding out whether you are dealing with a bony malignancy, bony tumor, or some soft tissue tumor. Okay. Then neurological symptoms. Okay, that is actually very important when you are taking a history of a bony swelling, especially in the periarticular region, means around the knee joint, shoulder, elbow, because all the critical neurovascular structures pass near the joint. They cross the joint. No, they give a blood supply, they give a nerve supply, and they cross the joint. So if any swelling which is arising from there, it might be possible that it might be involving the neurovascular structure. If it is involving the neurovascular structure, that is very important, because if it is completely encasing the structure, it might not be possible to salvage that limb. If popliteal artery or the femoral artery is directly involved, the sciatic nerve is involved in a primary bone malignancy, I am not going to tell the patient that I am going to salvage that limb, because it is not possible, because you will never get a margin. Okay, so if neurovascular structure is involved in a primary bone malignancy, chances are the patient will end up in an amputation, and most of the time you will find out in history itself. So a patient with a bony swelling around the knee joint comes with foot drop. What does it denote? Correct. There is a nerve involvement, na? So that is a direct indicator. So that's why I am saying history is very important. Examination is important. This is how history helps you. Because if there is a bony swelling and patient is around the knee joint and patient developing a foot drop, the chances are that the swelling is either compressing on that nerve or it has already encased the nerve. So then when you look at the scan also, first thing you will see is where is my neurovascular structure, whether it is salvageable or not. Because even then, if it is a primary bone malignancy and it is already involved in neurovascular structure, then there is no go. You are not going to salvage that limb. You are going to go off for only amputation. Okay, so those are some of the decisions which you can make in your clinics itself, just by talking to the patient, by examining the patient. You need not have a very fancy investigation like an MRI. You need not wait for it. Although you will not convey it to the patient, but in your mind you would have already made that most probably I am dealing with something for which I am most likely going to do this thing only. Because the clinical signs and symptoms are matching my diagnosis, and because the patient is already showing signs that his neurovascular structure is involved, it might not be possible for me to get a clearance. Okay, because see, in oncology, one of the most important thing is you never compromise margins just for the sake of function, except when it is benign bone tumors. Benign bone tumors which are locally aggressive, you can still try to salvage. Okay, but if it is a primary bone malignancy, you will never compromise your margins, because if it is a non-metastatic primary bone tumor, you have only one chance. If you fuck up that chance, it is gone, because the patient will have a recurrence at some point of time. Either it can be local recurrence, or if you contaminate the margins, even if you do a salvage, it will come with a recurrence, and it will come with such a recurrence that at next instant you might not have a chance to salvage also, or it will come with a systemic recurrence. So you have to have one chance only. You have to ensure that you get a clear margin. If in the bargain of getting a clear margin, you have to amputate that limb, you will do that. Because if it comes back systemically, then there is no way you can cure that patient. Okay. So how you work upon this patient? Any bony lesion? You are sitting in a clinic, na? So what you will ask for? So what X-ray you will ask? 12-year-old boy comes with a swelling around the knee joint. What X-ray you will ask for? Of which part? Knee with leg, knee with thigh? How you will know whether you have to take a knee with leg or a knee with thigh? Chalo, we'll go back. Okay, this patient, no? So what you will ask? Which X-ray you will ask? Knee with leg or knee with thigh? Why? Correct. That's the common sense. No, see, there is no swelling, clinical swelling in the leg, no. Even though I'll ask them to cover the proximal tibia, but my primary area of interest is the thigh. So if when you're writing an investigation, see, that's why I'm saying, clinical examination, why it is important is because it will influence your decisions completely. What investigation you are going to choose. what you're going to see. Everything costs money. Okay, you cannot write hundreds of X-rays for a single patient. Get the X-ray of the whole limb. You have to be choosy, no? And you have to do targeted investigation. So if I am having a swelling which is arising in the distal femur and come near the knee joint, I am not going to go for a leg X-ray, no? I will first get an X-ray of the knee with the thigh rather than a knee with leg. Okay, and AP lateral, always it has to be orthogonal views, means 90-degree angles. Okay, then why chest X-ray? Okay, correct. Sometimes it can be primary also. Multisystem, correct. So usually bone malignancy, if it is there, no, first most common site of metastasis in bone malignancy is lungs. Okay, so if a patient comes to you, a kid with a rapidly expanding lesion in the femur and already has 10 mets in the lung, which you can see on X-ray. If you are able to see those 10 mets on X-ray, chances are he might be having many more mets, which you will see on a CT scan. Okay, so then on day one, what is going to be management? Correct. So day one itself, you have made up your mind, na? That this is a patient which most likely might not be for a curative intent. This is a patient which will most likely go for a palliative intent. Although you won't convey this to the patient. And see, one dictum you have to always follow it. You have to confirm it yourself. Then only you are supposed to convey the information to the patient. If you have not convinced or you have not confirmed it, you are not going to volunteer that information to the patient or the relatives. Okay? But although you have made a medical plan or a clinical plan, but then you have to evaluate, you have to confirm your suspicion. Only once you have confirmed it, then only you are going to convey it to the patient. Never convey it without you confirming it. Because if it is something which could have been cured and you convey that it cannot be cured, you take away the patient and he goes to somebody else and they are diagnosed with something like that, then you will be landing up in soup. Giant cell tumors can present with lung metastasis. Rare but possible. Giant cell tumor is not a malignant lesion, it is a benign aggressive lesion. It can have lung mets which can be treated with medical therapy. So even if there are 10 mets are there, but if it is a GCT, then still you are going to go for a curative intent only. You are not going to push the patient for a palliative intent. Okay. Then MRI. Why MRI? Why not CT? Okay, lymph node you can do with USG also. CT also shows lymph nodes, na? Many of the disciplines don't use MRI, dedicated MRIs for their planning. Like head and neck, they will rarely use MRI. They will do their planning on CT only. So they will see the lymph nodes on CT only. It's not a lymphadenopathy cannot be diagnosed on CT scan. It can be diagnosed. Okay. See here, the aim is different. When you're dealing with bone, you're not just going to see the cortical structure. You have to see the marrow also. If there is a marrow metastasis there or there is a skip lesion in the marrow is there, you cannot diagnose it on a CT scan. So for marrow lesions, you have to have a MRI. Any other particular thing? They have written something besides that, na MRI. What I have written? So anybody knows what is the tumor protocol? Then you have to ask, no? I know everything, but you have to ask, no? You know everything about that, whatever I put on the board. So tumor protocol basically, see, when you are dealing with a primary bone malignancy or a bone tumor, no, we don't take a partial MRI. Means usually for, say, suppose the patient is having a sports injury around the knee joint, you will take only an MRI of the knee. But if I am suspecting a bone tumor of a distal femur, I won't take only a distal femur MRI. I will ask them to screen the whole limb. Means from hip to knee, the whole femur has to be included in the screening. Because, and if they find any skip lesions, my next direction will be to take axial cuts of that lesion. Because certain things like marrow lesions might not be visible on an X-ray. They will be visible on MRI. So when I am planning a resection or when I am planning a curative intent, surgical plan for that patient, then I have to include that marrow met in my resection also. And my plan might completely change based on that marrow met. The reconstruction might change. So that's why the whole femur has to be included. If it's a femur lesion, if it's a tibia lesion, then the MRI I will tell is you have to take an MRI from the knee joint to the ankle joint covering the whole tibia. Okay. Along with that, what I will ask is, I will ask for a contrast enhanced MRI. Not every time, but usually we ask for contrast analysis because if the lesion is very rapidly expanding, okay, suppose there is a very expanding lesion around the distal femur or proximal tibia, it is growing so fast that the center will be necrotic. So then how we are going to do a biopsy? If you take a biopsy from the necrotic component, the pathologist is going to tell, I am not able to find any viable tissue. I cannot give you a diagnosis. So MRI also helps you in planning your biopsies, because in MRI with the contrast, you can see which part is taking up the contrast. The part which is taking up the contrast is the viable part. So when you're targeting a biopsy, you have to take it from that part which is taking up the contrast, which is viable, so that you arrive at a diagnosis. If you take it from the necrotic area, you will not come with a diagnosis. Okay, so that's where MRI helps. Second thing is, one more thing, regarding decision making, neurovascular involvement. MRI, the planes are much more better appreciated compared to a CT scan. So if a neurovascular structure is abutting the tumor, then still I might go for a curative intent. But if it is completely encasing, even the nerve is encasing, then my plan might change. So that is better appreciated in MRI compared to a CT scan. Okay, so soft tissue enhancement is better, marrow lesions can be appreciated, neurovascular involvement can be better seen. Okay, third thing which is actually important is response assessment. If the patient has a primary bone malignancy which is chemosensitive, like osteo or Ewing sarcoma, we will start him on a chemotherapy. Later on, whether the chemotherapy is working or not, that might also influence your decision regarding what you are going to do with the patient. Suppose a patient presents to you with a 6 cm, 7 cm lesion, which is diagnosed to be Ewing sarcoma with a very large soft tissue component. You give 4 cycles of chemotherapy. Then you take an MRI and the tumor shows significant regression, means the soft tissue component is completely gone, now the lesion is only confined to the bone. So that means the chemotherapy is working. Compared to that, the same kind of diagnosis, 6 cm lesion of a Ewing sarcoma in a 12-year-old kid, and after 4 cycles of therapy, the lesion has increased in size. If it has increased in size, the chances are the chemotherapy is not working. So then again the concept of you have to counsel the patient that you might be in that group in which, although as of now we are not able to find any systemic mets, you will have to be in a much more vigilant about metastasis, or so surveillance might change because he has shown minimal or very poor response to chemotherapy, because that is a prognostic indicator for survival of the patient. Okay, so that's where an MRI helps. Then other baseline investigations, obviously, because you need to know that the patient has any other systemic disorder or not. Why we do PT-INR? But now we are not planning surgery, na? This is baseline investigation, no? PT-INR I'm asking. Liver problem you can get from LFT also. For liver problem you do LFT or PT-INR? Then why PT-INR? But it is a coagulation profile only, na? Why you do that? Correct. Hemophilia. Hemophilia can present with a bony swelling. Okay. Another thing is, if you are planning a biopsy, it is going to be needle biopsy, but again it's an invasive procedure. Okay. So sometimes the lesions can be quite vascular, because it's a tumor which is rapidly growing in size. It will be highly vascular. So if the PT-INR is also deranged, then you will wait for the PT-INR to at least normalize before you embark on a biopsy. Otherwise, patient might bleed too much. Okay, so that's why. See, each of those investigations gives you a clue how you're going to manage the patient, and it might alter your further investigation or management. So that's why it's there. Okay. Then serum calcium, phosphorus, kidney disease, what we are doing with the malignancy. Correct. Hyperparathyroidism. Okay. LFT, another thing why we see is alkaline phosphatase. If the patient has an alkaline phosphate which is in thousands, 2000, 3000, and he has a low calcium, high phosphorus, then not prostate cancer, hyperparathyroidism causes hypercalcemia, no? So patient is having elevated calcium, his alkaline phosphatase is also elevated, he is having multiple lesions. Okay. Then what you will consider it to be? Multiple lytic lesions are there. Multiple myeloma is then regarding parathyroid. Correct. So patients of hyperparathyroidism can present with multiple lytic lesions in the bone. They can present with hypercalcemia. For them, you are not going to opt for surgery, and they might present with pathological fractures also, multiple pathological fractures. In that, what is going to be a line of management? No man, hyperparathyroid, you have to find out now from where the parathyroid is coming. If it is a primary parathyroid adenoma, once you remove it, all the lesions will heal. Correct? Because the problem is excess of parathyroid hormone, not the bone malignancy. So that's why I'm saying you have to be very particular what you are thinking. You have to diagnose it correctly, no? If it is a hyperparathyroidism, primary hyperparathyroidism due to a parathyroid adenoma, you have to treat that adenoma rather than treating with that lytic lesion. Once you correct that hyperparathyroidism, that lesion is going to heal by itself. So for that, I am not going to advise a resection or a surgery, no. First, you will deal with the parathyroidism. Okay. Then last line, metastasis and myeloma workup. Okay, so 40 years, more than 40 years, usually you consider them most likely might be metastatic lesions. Okay, so the most common hematological malignancy is multiple myeloma, more than 40 years of age. So we always rule it out if a patient of more than 40 presents to us with a lytic bone lesion. Okay, and along with that, for metastasis, there are few blood investigation which we do. For in males, we do a PSA along with CA 19.9, which can give you a clue about abdominal malignancies and pancreatic cancer and CEA. For females, instead of PSA, we do CA 125 to rule out ovarian malignancies. Okay. Then based on the location, see how when you have seen a diagnosis on an X-ray that there is a bone lesion is there, then you have to read the X-ray. Okay. So again, a distal femur lesion, you will take an X-ray of knee with thigh to completely encompass that lesion in your X-ray. Then you have to critically evaluate that lesion, where that lesion is, where the site of growth is, whether it is in diaphysis, whether it is a metaphyseal lesion, whether it is an epiphyseal lesion, because based on that you will have your differentials. Okay, a young kid with a lytic lesion in the epiphysis, which has a well-defined sclerotic border, my first differential will be a chondroblastoma rather than a primary bone malignancy, because physeal lesions are usually chondroblastoma in that age group. Okay, so based on the location and the appearance on X-ray also, you will make a differential in your mind. Okay, then the morphology of the lesion. If it is a well-defined lesion with a very well-defined sclerotic rim, then most likely it might be a benign bone tumor rather than an aggressive tumor. Whereas when the margins are not clearly defined on the X-ray, they are ill-defined, then usually it's an aggressive lesion. It could be a benign aggressive lesion or it could be a malignancy itself. So based on the location around the knee, any tumor can present. Even a benign aggressive lesion like a GCT, ABC, aneurysmal bone cyst, chondromyxoid fibroma, chondroblastomas, the most common site is the knee. Okay. For osteosarcomas, Ewing sarcomas also, the most common location around the knee only. Okay. After that is shoulder, then pelvis. For chondrosarcomas, proximal femur, pelvis, scapula, axial locations are more common. Okay. But it's not like it cannot be present in diaphysis or around the knee joint. So here you can see the X-ray. So can anybody read the X-ray? First X-ray, no? What part of the body? Is it distal femur? It's a knee with leg X-ray, no? Which view? AP or lateral? Lateral view, correct. It's a lateral view, no? Because see the shape of the tibia, no? You are not able to see the condyles. You are seeing the tibia in lateral profile. Fibula is posterior. Part of the fibular head is covered by the tibia. So this is a lateral view. Continue. Then what do you see? Correct. It's not a cystic lesion. See, in bones we don't say cystic. Okay, we say lytic, lytic and sclerotic. Lytic basically means you are not finding any bone tissue over there. Means it's completely hollow because there is no calcium in that lesion. Sclerotic means there is too much of calcium compared to adjacent bone. Okay, so you have to compare the lesion with the adjacent bone. So now here you see the calcium distribution is fairly normal. Now suddenly there is a sclerotic rim is there. This is a sclerotic rim. Okay, you are able to see this is more white, no? This is more radiopaque compared to the adjacent bone. So this is a sclerotic rim. So the lesion is well defined because there is a sclerotic rim throughout, and across that sclerotic rim the bone is fairly normal, and there is a lytic with a slight expansile lesion with internal trabeculations. Okay, see, these are trabeculations, no? This you see, these are trabeculations. So it's a well defined lesion in the metadiaphysis of a proximal tibia with lytic and sclerotic component with internal trabeculations. So what will be a most probable differential? Is it a benign or malignant? Correct. Most likely it is benign. Most likely it is benign. Okay. Then another clue will be whether physis is fused or not. Physis is not fused. So then we are looking at a X-ray of a kid. Correct. So this is how you have to get the clues. So this is most probably a X-ray of a kid. X-ray, proximal tibia and fibula, proximal half of a kid with a lytic lesion with a well-defined sclerotic margin, internal trabeculations. So most probably it is a benign lesion. What could be differential for a benign lesion? Ewing sarcoma is not a benign lesion. It is a malignant, no? Benign is what? Osteosarcoma, but then it will not present like this. Osteosarcoma, what happens is, I will show you osteosarcoma also. So when a lytic lesion is an expansile lytic lesion in the metadiaphyseal region, the first most common differential will be anular bone cyst. ABC, GCT, these are your most common differentials, no? Okay, but it is not like on radiology it can never be, because it has to be a pathological diagnosis also. So in bone tumors we say onco-radiopathological correlation. There should be oncological correlation, means the signs and symptoms should match with the diagnosis which you have. There should be radiological correlation, means the X-ray should be showing what you have a diagnosis. The pathologist is saying a very well defined lesion is there. The pathologist is saying that it is a osteosarcoma. Then again I will ask them, please check again. Okay, although low grade osteosarcoma can present like this, but then again there should be a doubt whether we are dealing with it, and if there is a query also. Query osteosarcoma. Many times you will see reports, some outside lab will say query osteosarcoma, and they will give differentials like GCT, ABC and osteosarcoma. So you cannot have a malignant and a benign lesion as a differential. Either it has to be benign or it has to be malignant. That has to be told by the pathologist. If somebody is saying both can be a differential, then better you get an opinion from some other pathologist. Okay. Second X-ray. What part? What is this, man? You are a doctor now, na? You are a final year MBBS student. What this? Correct. So what we say is, yes, correct. Left or right? Correct. So left shoulder with arm, what you are able to find? Sorry? This is most likely an AP view. Yeah, because see the profile of the head, no? Scapula is here, it is not visible, but you can see the rim of the scapula. Glenoid, no? This is a glenoid rim. This is an AP view. Okay. So what again? Describe the lesion. Where are multiple lytic lesions? So are they multiple or part of the same lesion? See, again you have to see the lesion, no? So lesion is this single lesion only is there. There are parts where it is eroding the cortical bone. There are parts where it is not eroding the cortical bone, where the cortical bone is sclerotic. See, when a lesion develops in the bone, two things happen. One thing is the lesion will cause changes in the bone, and the bone will try to cause changes in the lesion. So you have to see what the lesion is doing to the bone, and then you have to see what the bone is doing to the lesion. So what will the bone try to do? Bone will try to heal that lesion. So that will lead to a sclerotic reaction, because bone will be trying to create a boundary around it of a sclerotic bone which will strengthen the walls so that it doesn't break. Lesion will try to cross that boundary and try to cause more bone destruction. So both things you have to see. So this is an expansile lesion, no? See, compare it. When you compare it, there is some expansion of the diaphysis there. First of all, location. What is the location? That is in analogy in Diaphysis, correct. So it's a diaphyseal lesion. Whether there is sclerotic rim is there or not, you are able to see the margin. You are able to make out the margins. There is a well-defined sclerotic. So there is a well-defined lesion in the diaphysis of the humerus, okay, with a well-defined sclerotic rim and with internal trabeculations. Correct. So then, most likely you are dealing with a benign or malignant. Why malignant? See, by basic concept you understand, no? When a lesion develops, the bone is trying to heal it. If it is able to contain that lesion within a sclerotic rim, means the bone is able to fight off that lesion. Okay? Malignancies progress very fast.